Good afternoon, and thank you for joining us for the Cancer Support Community's third annual Forum on Utilization Management Summit. I am Felicia Woods, the Executive Director of the Cancer Policy Institute, which is the policy and advocacy arm of CSC. Before we begin, just a few housekeeping items. Today's summit is being recorded and will be available for viewing afterwards. If you have any technical or administrative difficulties, please let us know by using the chat box at the bottom of the screen, and we will do our best to address them. Please submit your questions into the Q&A box throughout the presentations, and we will do our best to get to them during today's Q&A portions. This summit is the cornerstone event of CSC's Forum on Utilization Management, which fosters thoughtful discussions that engage a broad range of healthcare stakeholders and keeps the focus on patients. We ask tough questions about when various approaches are acceptable and when they have the potential to harm patient health outcomes, and identify new ideas and promising practices that optimize care based on evidence-based healthcare. In addition to our annual summit, we hosted roundtables throughout this year on leading edge issues, such as the copay accumulator adjustment program, how value is defined by different stakeholders, and precision medicine, and the future of value-based care. Last year's summit focused on what means on the ground for patients and caregivers, as well as for providers. We discussed when works well and where there are opportunities for improvement, and ultimately got a glimpse into the ways in which we currently navigate the healthcare system and how we might improve for the future. As a reminder, and for first-time attendees, practices have been one of the major ways in which untenable healthcare costs have been addressed. Includes step therapy, prior authorization, coverage with evidence development, pathways, and general discussions around the concept of value. Strategies are common, and when implemented appropriately, they can enhance the patient experience. However, they can also negatively impact patient access to care, as well as contribute to provider burden. Today's summit will examine how practices can increase health disparities. Today, we will have a keynote address and a fireside chat with Dr. Karen Winkfield, Executive Director of Meharry-Vanderbilt Alliance, followed by remarks from Dr. Danielle Carnival, Senior Advisor to the White House Director in the Office of Science and Technology and Policy. After our break, we'll be joined by a panel of healthcare experts to discuss how practices can increase health disparities. I also want to take a moment to thank our sponsors. As always, CSC is committed to fostering conversations that inform and engage all stakeholders in the creation and implementation of strategies that include the patient perspectives and incentivize cost efficiency through improved patient care and outcomes. We all have a role to play in making healthcare accessible, available, and of high quality. Now, before we start today's program, I want to play a short video about the Forum on that was recently featured at BIO's Patient and Health Advocacy Digital Summit. Listen as Stephanie discusses her journey and accessing much needed care.
For years, I suffered debilitating symptoms before I was finally diagnosed with Crohn's disease. At that time, I was out on an island alone, trying to figure out this incurable disease. I have what's considered metastatic Crohn's disease, which means that it affects just about every part of my body and has resulted in debilitating arthritis, neuropathy, skin issues, vision issues, as well as my inability to have children naturally. For years, my condition progressed uncontrollably and unnecessarily because of the protocols that are in place by healthcare providers to mitigate costs of healthcare.
Utilization management is a very unfamiliar term to a lot of people, but the techniques I'm sure are pretty familiar to a lot of patients. So those techniques can be step therapy, which requires patients to fail first on an insurance preferred drug before taking something that may be originally prescribed by that patient's provider. My role at the Cancer Support Community is to lead the Cancer Policy Institute. As we know, a collective voice creates change. And CPI has become a convener and a leader in really promoting patient-centered public policies. The Forum on Utilization Management was created back in 2019. And our main mission was to convene other patient advocacy organizations to talk about how are utilization management techniques affecting our patient population and what can we be doing to create a more patient-centered approach.
Utilization management can be devastating for people living with chronic illnesses. This forum has a goal of uniting communities across the board of disease states and becoming a unified collaboration for change. I was a part of the step therapy reform that passed here in Georgia in 2019. And that was in collaboration with organizations that came together and collaborated on a mission to enact change for the patient. I think having an advocate like Stephanie be at the center of the discussion is crucial. She is one of the ones that we want to take to Capitol Hill or want to take to the state level to really show policymakers that the decisions being made are directly influencing people, and we need effective policies to work in order for them to take back their lives from the diseases that they're facing. I'm grateful that God has given me this opportunity to share. I'm grateful that my life now has meaning and purpose, even with this disease, in spite of this disease, that I am making change, and that change feels good. What a powerful story, and we are so honored to highlight Stephanie today in that video and thank her for being willing to tell her story. Now we will welcome Dr. Karen Winkfield to the virtual stage. Dr. Karen Winkfield is a radiation oncologist specializing in the treatment of hematologic and breast cancer malignancies. As the executive director of the Meharry-Vanderbilt Alliance, she leverages her expertise as an implementation scientist to focus on improving health outcomes for underserved populations through community engaged research and community-based initiatives designed to improve access to healthcare, including clinical trials. Her leadership roles have focused on developing bi-directional communication between researchers and community to ensure equitable access to care regardless of race and ethnicity, geographic location, or socioeconomic states. She is a thought leader espousing the importance of workforce diversity to improve health equity. Dr. Winkfield was recently appointed by President Biden to the National Cancer Advisory Board. Welcome, Dr. Winkfield.
Dr. Woods, thank you so much. Really appreciate being here. And thank you so much to everyone who's attending today. Man, wasn't Stephanie's experience just powerful? So this is the importance of patient voice, right? A lot of times we find that our patients are not oftentimes front and center, that their voices are not front and center, but I'm so grateful that we had an opportunity to hear from Stephanie today. Let me just make sure that you guys can see this screen okay. Just see, are we doing okay, Dr. Woods? Can you see the slide deck?
I can see that it says you have started sharing your screen, but I don't see the slide deck just yet.
All right, let's see if I can pull this up, folks. This is why we practice and it still doesn't work, but that's all right. All right, what about now? No?
Not yet.
Okay, let's see. All right, let's see if this one will work. I'm getting an error now, so let's see.
I know.
Let's see if we can do this. Okay. All right, how about now?
Yep, we're in business.
Oh, very good. Thank you all for your patience. I tell you, this whole COVID thing, I'll be ready to get back to in-person meetings quite soon. So thank you so much all once again for your patience and for being here. As noted, I'm a radiation oncologist, but I've worked in this health equity space for quite some time. Here are my disclosures, and please feel free to follow, like, share my social media. We talk a lot about utilization management. You heard Dr. Woods describe what it is, and also to talk a little bit, and you heard from Stephanie about how it's impacted her life. But it's interesting, these definitions are not new. The Institutes of Medicine had this definition of a set of techniques used by or on behalf of purchasers of healthcare benefits to manage healthcare costs by influencing the patient care and decision making through a case-by-case assessment of the appropriateness of care. Now, let me just state that this is not being forced on patients by their providers. Okay, I just want to make that clear. And so in some ways, to restate, it's really techniques used by or on behalf of insurance carriers to manage costs. Okay, because let me tell you, as a provider, as a radiation oncologist, I have had patients for whom I have had to go through a prior authorization for radiation therapy. This patient has breast cancer, and I have to go through a process by which I have someone who is not necessarily even a physician, but may not even be in the field of oncology, let alone radiation oncology, who speaks to me to say, why are you trying to do this? Why are you trying to actually give this patient this number of treatments versus a different number that they deem is appropriate? And so from a provider perspective, it's troublesome. It takes time. It costs money to do these sorts of prior authorizations. And in fact, I had one of my trainees, one of the residents at Vanderbilt University Medical Center, he's in the Department of Radiation, Dr. Brian Bingham, actually published an abstract and discussed it at our annual meeting this past year in October, where he said, and he had done the research to show that for prior authorization for radiation oncologists, it costs $40 million a year for providers to do that. Not only just the physicians, but you have to remember a lot of the care that we give around cancer is very, very comprehensive. We have nursing staff and radiation therapists. We have dosimetrists and physicists who work with us in radiation. And so the costs associated with some of these utilization management techniques are actually costly, not just to providers, but to patients, as you heard from Stephanie. And so I do want to kind of use this definition around, techniques used by and on behalf of insurance carriers, because I think it'll help frame some of the conversations we have. Okay, you've already heard about, limitation of quantity. I get that with respect to how many treatments of radiation can I give. I've got someone who's not a radiation oncologist dictating that to me, but prior authorization, getting approval, step therapy, as you've heard Stephanie discuss, and provider prescribing limits. So these are some opportunities for us to kind of discuss how utilization management is impacting us. Now, why is this even the case? You heard Dr. Woods talk about the fact that we are trying to contain costs in the United States, and we have to. I mean, we spend more dollars per capita, more healthcare dollars than any other nation, right? And so when you think about the fact that our care costs, and I haven't even shown you the trillions and trillions of dollars that are being spent, this is really just looking at a per capita, meaning each individual, how much are we spending? It well exceeds what most other nations are doing. And it's putting us in a precarious position. So we do have to do some cost containment, but is that really the way to go about doing it? When we look at where healthcare dollars are being spent, all right, again, this is a comparison of the United States and the first column on the left compared to other developing nations. We see that across the board, it doesn't matter if you're talking about inpatient, so hospital nursing care, so that's what the blue is, if for those of you who can see colors here, for ambulatory care, meaning outpatient, that includes radiologic subspecialties, other things, we are kind of far exceeding the costs that we see in other nations. And certainly here, we think about pharmaceuticals, we also are spending a lot more. Some of that's related to the fact that a drug that's here in the United States may cost more money than what it costs in other countries even. So there's a lot that we need to do in terms of thinking about cost containment and value-based care, but it's important to think about who these sorts of techniques actually impact, and that's the patients, that's the population. So that's why I'm really grateful that we started out with hearing a story from a patient. Well, who is actually spending the healthcare dollars? Where is it being spent? It's interesting to think that the top 1% of spending in healthcare actually is only, taken up by 1% of the population. And in our country, it's because older adults tend to consume more healthcare dollars, and that can be part of the issue. Remember, if you think about that last slide that I showed, going into this actually includes nursing homes, the area in the blue. And so if you think about the way other countries might be set up, there may be a different care model. The bottom line is these are things that we have got to address. Yes, we have to address cost, but my concern is this. We know that healthcare dollars are not spent equitably in different communities. And we already know that healthcare disparities exist across the board, not just in cancer. Again, yeah, I'm an oncologist, but it's really important to understand the fact that obesity, which is an epidemic in this country, particularly among African Americans and rising rates in Hispanic, that we've got to handle because it impacts our ability not only to develop, it increases risk for the development of other diseases, including cancer, but it also impacts and affects our ability to treat effectively. These healthcare disparities are wide ranging. Again, obesity, HIV. And so, if we think about the fact that not all people are being impacted the way we'd like to with all of the amazing treatments. And let me just give the example of cancer again. I'm an oncologist, so I'm going to go there. Last year, in September of 2020, the AACR, the American Association for Cancer Research, actually published their very first Disparities Progress Report on cancer. And again, beautiful. We are doing a wonderful job. We're closing some of the treatment gaps. But unfortunately, if you look at the trends in terms of cancer death rates, we see that African Americans, the top line here, still have the highest risk of mortality, death related to cancer. There is a gap there. Why is that? Well, you think about it, it's not just related to cancer. As I showed you, all of those other areas where there's risk. But here's the thing that bothers me, probably more than all of those other things. Maternal mortality rates. If we look in the United States, we have Black women who are dying as they're giving birth at much higher rates than any other racial ethnic group. And sometimes those rates are even higher than what we're seeing in developing nations. Again, if we're spending all these dollars on healthcare, where are those dollars going? Certainly it's not being distributed equitably amongst different communities. And in fact, if we look at healthcare disparities, I apologize, my slides are doing weird things, but we know that we're spending over $1 trillion annually. If we look at the economic cost of cancer health disparities, just cancer health disparities, it costs this nation money. So we've got to think about what we're doing from a policy perspective to help drive the needle and make sure that the changes that we're suggesting from a policy perspective are not going to further exacerbate these disparities, because the disparities cost money too. I hate using that because frankly, we should be thinking about healthcare disparities because it's the right thing to do, because we believe that everyone deserves to have access to healthcare, but we know that that sentiment is not distributed equally amongst the United States population. But this argument, the argument about cost, is one of these that we've got to be thoughtful about in our discussion today. We've heard over and over again, healthcare disparities, nature versus nurture. Look, I'm a biochemist, I'm a basic scientist, and I do believe that there may be some biologic determinants that we can pick up, right? BRCA1 kind of being more predominant in Ashkenazi Jews and in African-American women, right? So biologic determinant that may impact the stage at which a woman presents with breast cancer or their ability to access different types of therapy. But frankly, the issue of social determinants is more predominant. This is really where the money lies. And in fact, this is not new. Back in 1999, the Institutes of Medicine actually provided a report to the NIH, National Institutes of Health, talking about their research program, talking about the fact that we need to move away from race-based thoughts about the fundamental biologic differences. We know that race is a social construct. It's not biologic. And so the recommendation back over 20 years ago was to focus on environmental living conditions and other factors. And that is indeed the social determinants of health. This is a great slide. I love this, from Kaiser Family Foundation. For those folks who might not kind of think broadly about these issues, it kind of breaks things down into several distinct buckets: economic stability, neighborhood physical environment, education, food, et cetera. And you sometimes might not even think about how this can impact health, well-being, and access to health care. We know that employment varies by individual. It's impacted by education, but it also is impacted by other isms, racism, sexism, other isms that we see in our communities, right? But how does that impact health? Well, obviously wealth impacts health, right? Wealth is health. If you don't have the finances to pay for transportation even, right? So that's one of the next categories, but finances to pay for drug copays, or if indeed your treatment gets denied, or you're asked to start back and retake a medicine that you've already taken and failed, that's step therapy. Why should you have to do that and expend costs out of pocket because somebody else is making these determinations of what's best for you? The social determinants of health are things that we need to keep in mind, particularly if we're thinking about creating new legislation, or even thinking about what we can do as individuals, as providers, as sponsors of program, as researchers. The social determinants of health are really important to keep front and center because they impact every part of health and well-being. Think about this. When I was in Boston, I was on treating patients, and oftentimes my patients would be like a little bit late. And I'm like, oh, is everything okay? Oh yeah, but I have to take 2 buses and a train to get here. Despite the fact that they probably lived less than 10 miles away, that transportation loop actually took them more than an hour sometimes to get to their appointment. Think about a different thing. When I was at Wake Forest, I had patients who were driving 200 miles to come and see me, rural patient population. But their drive was not straight. It wasn't 200 miles straight. There's oftentimes lots of barriers, just in terms of thinking about the fact that a 100-mile drive may be not taking 90 minutes. It might be taking much longer than that. These are the things that we need to keep in mind. Food insecurity, I think this is another tragedy that we see in this nation, one of the wealthiest, where, and this was old data, more than 48 million Americans living in food insecure households in 2014. Imagine what it's like now post-COVID, when people lost their jobs, lost their employment. And so these social determinants of health impact whether or not people can actually access healthcare. This is one of the reasons why the obesity epidemic is so robust. Right? Food insecurity isn't just about, do you have access to food? It's, do you have access to healthy foods? Do you live in a food desert? Are there fresh fruits and vegetables nearby? Or are you getting most of your sustenance from fast foods and other processed foods? This is all part of food insecurity, and it does impact health. So these are the things I want us to keep in mind as we're thinking about this issue of utilization management. Because the fact of the matter is that medical care itself only accounts for about 20 to 25% of population health. Okay. And I think that's something where we have to be mindful of, that our tax dollars going towards providing services, the services include community. The services that we're paying our tax dollars for include access to walkability, right? Are we having good roads? Do we have a place where our children can play? These are all the things that actually go into determining health and well-being. Part of the challenge, I think, is how we think about healthcare in the United States, or even health. Our definition of health sometimes is the absence of disease. And my thought today, and my hope is we can actually have this conversation, it goes beyond that. It goes to really speaking about the total ecology that a patient feels, their well-being, their sense of well-being. And I think that's something to keep in mind. So when we're having restrictions in terms of what medicines a patient can take, as you heard Stephanie talk about, she had to suffer because some individual, some entity was dictating her treatment course. And they oftentimes are not even a clinician. We do know that when it comes to utilization management, they oftentimes utilize nursing staff to kind of look at guidelines to help to determine whether or not this is going to be something that the company pays for or not. It's really important, again, for everyone who's part of this process to really take a step back and think about these social determinants of health. And what are the ways that we can work together, all of the stakeholders, to really address some of these issues in a more meaningful way? I want to point out this article that my colleagues and I published earlier this year in January, where we actually pulled together stakeholders from around the country and really said, how can we actually improve some of the disparities that we're seeing in cancer care? And I must say, this was pre-COVID that we did this. We did actually pull together the roundtable in 2018, but what we realized as we were writing this up is that the principles that are in this particular article are broadly applicable for most chronic conditions, okay? So if you think about rheumatoid arthritis, if you think about hypertension or diabetes or renal failure, a lot of the things that we discuss in this particular paper, in this framework, are broadly applicable across different disease states. So my hope is that you all will take a look at it. It was published in the Journal of Oncology Practice, but certainly, again, the principles of how do we bridge the gaps? How do we make sure we're thinking about populations in a different way from a healthcare perspective are really broadly applicable. We talk about the different stakeholders. And like I said, this issue of utilization management, we have got to pull the stakeholders together. We all have to be thinking strategically about the patients and kind of thinking about the patient voice. But how do we do that? We do that by including them and making sure that they have a seat at the table when we're actually designing things. How about that? Asking patients what their needs are. But it also includes broader stakeholders, including our legislators, including the individuals who are making decisions for insurance plans. These are all the stakeholders who we need to kind of pull together to help implement this framework. And thinking about other medically underserved populations. Again, I mentioned African Americans, certainly racial ethnic groups we know are some of the most disenfranchised groups, but it also includes the LGBTQ plus community. It also includes adolescents and young adults who oftentimes fall in this weird wonky place where their insurance coverage may change all the time, and that has implications for step therapy, right? Or for older adults who may be on one plan or another, again, implications for step therapy. So really important to think about the different types of populations and underserved populations and how the decisions that are being made might impact them. One of the things that we really wanted to highlight in this paper is the importance of community engagement. Again, you already heard that I mentioned this framework and saying we've got to have the stakeholders at the table. And I think that's what I'm hoping that we'll have some discussion with Dr. Woods. We're going to have this little fireside chat and talk a little bit about what each of us can do, what are the different stakeholders, and what are the ways that we can actually help to address some of these issues. We are, as Americans, able to kind of have a voice. We have to know what some of the issues are. We have to know what some of the policies are that are at the table so that we can utilize our voice. But really important to also think about what resourcing can be done now, because we know that the legislative process takes time. What are some of the ways now that we can bridge the gap? And you'll see in this particular paper, if you take a look at it, we talk about navigation, et cetera. And I think these are some things that can be done and implemented now. So my hope is that this broad framework in terms of thinking about elements of equity, think about people, think about the patients, think about the individuals, and I don't want to just use patients because we need to think about prevention. We need to think about all of the issues related to health and health equity. People matter, place matters, the community that you find yourselves, but certainly policy matters. So I really am excited to have a conversation now with Dr. Woods, and I'm going to turn it back over to her, and so that we can start this fireside chat.
All right. Well, I'm excited as well. That was just amazing. And honestly, the questions are pouring in. So everybody is fired up to really just talk to you, Dr. Winkfield. And I would love to just start with a global equity question. I mean, you really looked into the issue of social safety nets and talking about social determinants of health and what we really need to be focusing on. And you know, many of our organizations are being more thoughtful when it comes to examining health equity. There's a variety of organizations on this call, from payers to industry to patient advocacy organizations. We're thinking about equity and inclusion. But when we think about inclusion, there needs to be another step, engagement. And I looked at some of and looking at your slides, I really want to know, how are you working as a provider in the community, working to really look at those social determinants of health and not just have people at the table or in the room, but how are they engaged in that policy decision-making internally, externally, or even within the community? How can we be doing a better job?
Yeah, it's a great question. And I think there's so much more we need to do. People mistake outreach with engagement. And so, I tell people I'm a community engagement specialist and I believe in being boots on the ground. And like I said, we need to be doing more in terms of just asking individuals what their needs are. Because there's a lot of assumptions that get made. There are a lot of folks who are sitting in ivory towers and saying, oh, well, look, the population needs this, but they're not asking people what their needs are. That's the difference between outreach and engagement. And we saw that front and center during this pandemic, right? Where there's a lot of research. Look, we all know that mRNA vaccines are not new, right? We've been studying them for a long time. We all know that coronaviruses are not new, been studied for decades, right? But because the messaging wasn't put together in a way that resonated with people, we are still struggling with getting our vaccination rates up in this country, right? So this shows that it's not just about outreach and saying, oh, look what we did, and I'm going to show it to you and now take this. No, we need to be early on having conversations, bi-directional conversations about the things that matter, the things that are important. So if we say that health matters, if we say that health equity matters, if we say that inclusion matters in terms of including voices of patients, families, communities at the table when we're making decisions, that means getting them on board early, not when you have a problem, right? So this is why I love the fact that the state cancer plans, and again, I'm going to use cancer because that's the example I know, but a lot of the state cancer plans actually do kind of think longitudinally about the things that they want to kind of address over a long period of time, but they start thinking about how do we make sure that we have patient advocates at the table, the patient voices, family members, et cetera, so that we can be strategic in the way that we engage. Look, we still have a long way to go, but engagement requires being at the table, front and center, not because you need something. It cannot be transactional, but really just because you are hoping to hear something from the communities to find out where they are and meet them where they are. And I must say that's timely. So it takes time, it costs money, and oftentimes the research dollars are not going to pay for that. So this is where our partners need to come together. This is where pharma, sponsors, insurers need to say, look, we value population health. And we want to make sure that we have the infrastructure in place that when issues arise, when we do need to do research, that we actually have a community that trusts us so that we can do that work.
Yeah, 100%. And this next question goes along with what we're talking about here about that community engagement. But looking at patient navigation, I think that's a critical part of investment. So how do we invest and ensure that sustainability? Because I often look at my grandmother, I use her as an example all the time, that care coordination. She has her provider, she has her nursing team, her caregivers, but we need all those people connected to ensure sustainability within the community. So how do we accomplish that? I know it's a lot to accomplish, but how do we?
Well, listen, I know you're asking the question because I've done some things in this space. And so I'm a believer in when patients or when individuals do have a medical issue, the onus should not be on them to try to figure out how to navigate. I mean, that shows how complex our system is. And I say this because, look, my husband, before he passed away, was an avid consumer of the healthcare system. And he had a nephrologist and a cardiologist, and he had all the ologists, right? And I watched him, smart man, but he was still being shuttled from one person to the next. But I was in the system and still sometimes struggling with how to navigate that, right? So imagine you have a very complex diagnosis, HIV/AIDS, or you have rheumatoid arthritis where you need access to physical therapy, OT. Who's going to be managing that? It can be a full-time job. And again, the whole discussion around equity, some people don't have the capacity to do that because they may be working a full-time job already, and they don't have the time to then navigate themselves. So I am a huge proponent of utilizing navigators in all forms. I love my nurse navigators. They can help provide a lot of education and information around treatments and making sure that people get from one specialist to the next. But frankly, a lot of the issues with respect to the social determinants of health are going to be managed by population health navigators. And so I actually established a program at Wake Forest when I was there, where we took lay individuals, and I'm using air quotes because one of them was a lawyer, we had a social worker, they were just non-nurse navigators. But what they were able to do was start in the community. So going back to your last comment about the importance of community engagement, being part of the community, doing outreach during the, and engagement during the year. And then kind of being a trusted advisor. So, we've had patients, who are like, oh my goodness, I was just diagnosed with cancer. I've got to come to the center. I got your card at the last, health fair. Can I talk with you? That actually helps to bridge and allow for patients who are coming into a system to really have somebody who can help navigate them and shuttle them through, and actually provide resourcing around the psychosocial component of a diagnosis or a chronic illness, right? Those are all important things that oftentimes our nurse navigators, they need to be focused more on the clinical component and teaching that. So I love the community health worker kind of model. And in fact, Harold Freeman, right, the father of navigation, he utilized community-based individuals, people who are from and of the communities that we're trying to serve, to really help to provide an opportunity for more enriched engagement with those communities.
Well, you just spoke CSC's love language, psychosocial care. That's all that we do and focus on. And that community-based care is important in our network partners. And how do we reach out to them to provide that making sure looking after their well-being, the caregivers, and also the family and friends, as well as the patients too. So we have a question from the audience that talks about the IOM. The IOM definition of you shared says it is to influence patient care, decision-making through case-by-case assessments of the appropriateness of care. But methods are widely cast and routinely used, not used on a case-by-case basis. What policies can be implemented to have the use and application of how can we being first with a case-by-case assessment and not routinely applied to all?
Wow, that's a big question.
It's a lot to dive into.
And look, I think that's frankly above my pay grade, because I don't feel like utilization management actually helps most patients, right? It's not about the patients. So let's make that clear. is not about improving patient care. It may kind of help maybe 7-10% max of patients, but really that's not where the focus is. The focus is on cost savings for the insurer, okay? So I think this is where policy comes into play to say, look, this is causing burden to our providers. This is causing patient burden, and putting some guardrails around the use of this policy. And again, I'm just going to say this. I probably shouldn't say this, but I'm going to say it anyway. I believe that the whole healthcare system needs a 100% overhaul. All right, I'm just going to put it out there, because the way that we actually tie insurance to employment disenfranchises people, right? You think about, again, we talked a little about socioeconomic status, income, education, occupation. The fact that somebody can have better insurance just because of the job that they have is problematic. But that also sets up a dynamic where insurers can be like, well, I've got this patient population and they're working, and so that means that they're potentially healthier, or whatever the rationale, that they have an actuary who's going through and creating these kind of things. So trust me, there's oftentimes not even a provider who's who's making these decisions. So I think that the whole system needs an overhaul, but I think with respect to what can be done now, that's probably a bit above my pay grade, because frankly, I feel like the reasons why is being implemented has nothing to do with the patients, despite that definition from the Institutes of Medicine. That's what it's supposed to be, but that's why I showed you that secondary definition.
Right, and honestly, that's why we all need to be in forums like this, so we can understand what the burden is and figure out, and going back to our respective communities as it comes to healthcare, and figuring out what we can be doing to provide better care for our patients, and also uplift everyone when we're advocating for different policies, and talk to policymakers at both the federal and the state level about the various practices that create burdens for patients. I want to go back to your talk when you spoke specifically about the provider burden. That really resonated with me, because I know providers do have to spend the time, especially, their front desk workers, trying to call in about prior authorization, or even with step therapy. So how do we account for the fact that insurance companies focus on cost savings, yet it costs $40 million per year for providers to do And I want to add on to that question just a little bit there, because there's a patient component to that. while you're on the phone talking to the insurance companies, the patient themselves are probably at home stewing, trying to figure out, is this going to be paid for?
Yes.
So how do you manage that as a physician and a provider?
Yeah. So let me clarify that $40 million was just for radiation oncology. All right. I just want to clarify that's only one specialty group. So I think the AMA may have a more robust data around what's happening globally. But let me tell you, you said exactly the thing that's so important. I can't tell you how many times I've had patients who come in that I've actually said, this is the plan for radiation, and they come freaking out because they're like, oh my goodness, my insurance just denied my care. What do I do? And it puts the provider again in another situation. To your point, you've got the patient who's now like, oh my goodness, like, what do I do? This is, and it actually causes distrust sometimes because the patient's like, well, are you not treating me the right way? Right? Why did they decline this? And so I think it is really important to make sure, again, whoever's making these decisions, our legislators, to understand the burden on the patients and also the providers, because it really is difficult. And then it does set up some kind of dynamics that can be a little bit challenging. So a lot of times what I'll do, and I shouldn't have to do this, right? Again, I am a radiation oncologist who works in an academic setting. So sometimes I don't even know what insurance a person has that's sitting in front of me. So it's really hard for me to say, oh, well, you have X, Y, and Z insurance. You may have to, we may have to do this check. So oftentimes it is on the back end. And again, to your point, it can cause some distress. But I think the more important thing for us to do as providers is, number one, be aware of the issues and to really advocate, and to do it from a legislative perspective. So working with our patient advocacy groups, working with folks like CSC, working with ACS-CAN, working with the American Society of Clinical Oncology, and to say, look, we need to do a better job nationally with respect to these techniques that are really causing undue burden and added stress to patients who are already undergoing care and trying to get the care that they need and that they deserve without having to worry about prior authorizations or step therapy or any of that stuff.
Well, how do you, as a provider, talk to your patient about I imagine that conversations can be difficult, especially someone who's, trying to go through their treatment journey and probably sees this as a hiccup or deterrence in actually getting the care that they need.
Yes.
And then you think about communities of color when it comes to like just mistrust in the healthcare system. How do you talk to them about
Yeah. So this is where kind of trying to empower patients to get engaged helps. Again, they shouldn't have to do this, but oftentimes what will happen is, to your point, their treatment gets delayed. Right. So I have to call the patient saying, by the way, I got a call from your insurer today that they want me to kind of review the plan. This is kind of, unfortunately, it's one of these things where I have to do it. And it's not just a front desk person. Let me just tell you, I, as the clinician, as the provider, oftentimes have to get on the phone. So I have to take time from another patient or from doing another patient plan to kind of get on the phone and wait on the phone. They do try to schedule it. Thank you very much. But oftentimes then I'm speaking with a nurse who may not actually even have any oncology specialty. I've then been passed off to an OBGYN who has no knowledge of what I'm doing as a radiation oncologist. So it's time consuming and it takes you away from doing the things you need to do. But I tell you, one of the things I empower my patients said, look, I'm so sorry that this is happening. I understand that the delays in your care can be causing you some distress. My recommendation, if you don't mind, if you can help me, would you mind calling your insurance company? Would you mind just giving them a call and finding out the rationale? And, sometimes it's really important to make sure the patients understand you might not feel like you're doing anything. You might feel hopeless, but you're not. And empowering them to say, hey, if you can pick up the phone call, that might help to move things along. I'm going to do my part. My team and I are going to do my part to move this along, but really important to empower them to also kind of engage in that process. And more importantly, and this is one of the things that I talk about more, not necessarily with my patients that I'm treating, but in the community engagement work I do, is I actually really talk about the importance of advocacy, really talk about the importance of making sure that we are front and center, that we're having conversations with our legislators, or when there are issues that are coming up, that we actually lend our voice to really help to support the good work that's already happening.
Awesome. So I have one more question as we begin to wind down our fireside chat, although I could continue this for a long time. It is related to precision medicine. So the last 20 years, we've seen some insight into human biology, genomics, and the promise of personalized medicine. And as we get closer to that reality and the practice of personalized medicine, how can we make sure that it is equitable? Because right now, that promise could be a peril for somebody else, for communities that are not actively engaged or even understanding of what precision medicine is. So how can we ensure equitable equity in precision medicine?
So you are like all in my head. So last week, I actually gave the keynote, one of the keynotes at the Cancer Foundation Symposium, and my title was Precision Medicine, the right treatment for the right patient at the right time. And oftentimes the terminology gets used more around like precision oncology or testing and kind of making sure you have the appropriate test. And that's a part of it. But frankly, in this country, again, we still have patients, to your point, that aren't even getting standard testing, right? Because of whatever the system failures are. If you look, for instance, and I'm going to use breast cancer again as an example, we have a test called Oncotype DX, which we actually can help to determine whether or not a woman who has localized breast cancer would benefit from chemotherapy or not. It should be a cost saving that actually is utilized to say, look, do we need to give a patient an expensive chemotherapeutic or one that's going to cause toxicity, or is she safe enough? Is the risk low enough? The risk of something going elsewhere low enough where we can avoid giving her chemotherapy? Well, do you know that African-American women actually don't get that test at the same rate as other racial and ethnic groups? Like, what the heck? It's a standard thing. So I do have concerns about precision oncology and the way that we define precision medicine, but the way that my talk actually shaped it is precision medicine needs to include the social determinants of health. Okay. That's how you personalize medicine. That's how you personalize care, is seeing the person in front of you, saying, what are your needs? It's not just about a test. It's not just about whether or not, this person has this mutation or another. It's about seeing the person who's sitting in front of you and meeting their needs. That's what personalized medicine should be.
Awesome. Thank you. And that's something for us to definitely think about as we move towards that space. And I know CSC will be focusing on a little bit more on precision medicine and looking at the equity components next year. So I just want to thank you for your time and thank you for sitting with us and talking more in-depthly about UN practices and health equity. It's really just been a privilege to talk to you and engage. And I look forward to more conversations. So we're going to move forward with the program. We have Dr. Danielle Carnival on with us, and I will introduce her in just 2 seconds. So Dr. Carnival currently serves as Senior Advisor to the Director of the Office of Science, Technology, and Policy, where she drives initiatives for people living with cancer and a host of other devastating diagnoses. Dr. Carnival was previously the CEO of IMALS, a nonprofit that focuses on atrophic lateral sclerosis, a neurodegenerative disease, She provided strategic leadership and management to this patient-led, patient-centric community that is reshaping public understanding of this disease, providing key resources to the community and creating opportunities for patients to lead the fight against ALS and search for cures. Dr. Carnival was formerly the Vice President of the Fighting Cancer Initiative, where she led organizational, program, policy, and partnership development. She was integral in developing and managing the execution of the goals for the Cancer Moonshot. Dr. Carnival earned her PhD in neuroscience at Georgetown University and BS in biochemistry at Boston College. Welcome, Dr. Carnival.
Thank you, Felicia, and thank you for having me here today. And to everyone watching, to you and the organizations and institutions you represent for the work you do every day for people facing a cancer diagnosis. That deep respect and admiration is true under normal circumstances, but I want to acknowledge the extraordinary lengths that I know each and every one of you and your entities went to during the last 20 months to ensure that people living with cancer didn't experience any less urgency, support, or quality of care. As the oncology community spends this year commemorating the 50th anniversary of the signing of the National Cancer Act, I know it has been a year of reflection in many ways. Cancer mortality rates have been declining over the past 30 years, and the rate of that decline has been accelerating. We have more understanding of the underlying mechanisms of cancer, including genetics, genomics, and the interaction with the immune system. We have more tools to prevent and detect cancer. We have increased outreach to medically underserved communities to address gaps in access to care. And although many factors contribute to this trend, more effective treatments are definitely a driving force in recent years. So many people and institutions represented here have extended, saved, and changed the lives of countless people, families, entire communities. There is so much to be proud of and celebrated in how far we've come in 50 years, or even in 5 years since the launch of the Cancer Moonshot. Some of the highlights since 5 years ago include more than 1,000 papers published reporting on moonshot-supported research, more than $1 billion in research, 240 research projects, 70 consortiums or programs, new patient engagement programs, an NCI Cancer Research Data Commons, a Tumor Atlas Network, a partnership for accelerating cancer therapies, new partnerships between the Department of Defense, the VA, and the National Cancer Institute to understand cancer in our servicemen and women and veterans, funding and policies delivered in the 21st Century Cures Act, including the Oncology Center of Excellence at the FDA. But given all of this, as we all know, there is still so much to be done. We have remaining issues. There are remaining issues in how we know cancer today. We know cancer still as a disease for which we don't have enough tools to prevent it, and we don't effectively use all the ones we have, as a disease for which we don't routinely detect it early enough when it is most treatable and often with less invasive treatment. We have inequities in time to diagnosis, in access to treatments, trials, care, and outcomes based on who you are and where you live. I know a lot of that conversation is happening during this meeting today. We know more about the genetics of cancer than ever before, and yet we are not fully acting on familial or hereditary risk and providing people with the tools they need to live as long and healthy a life as possible. We still lack solutions for the toughest, deadliest, and rarest cancers, and cancer is a disease for which we don't have the systems to learn for every patient or the systems to share data and knowledge widely. The good news is that President Biden knows cancer. He knows it personally and has taken it on as a national and global leader in making urgent progress for people facing this disease. As he has said, he is committed to doing everything in his power to end cancer as we know it. From the start, this work has been about injecting urgency to our collective approach, bringing all possible solutions and partners, including all of you, to the table with ideas and action, providing an avenue to hear and prioritize what patients and caregivers identify as being most important, changing the systems and culture to meet this moment, and delivering on the hope felt by millions of families facing a cancer diagnosis. He's already made a down payment on this promise by proposing strong funding of NIH, of NCI, and in proposing a bold new approach to taking on some of the remaining issues facing biomedical research and those living with diseases like cancer, in proposing and continuing to fight to make real an ARPA for health, ARPA-H. This administration has supported more people getting quality and affordable health insurance, but we know we still need to make strides to ensure that everyone in the United States has the best in cancer prevention, early detection, treatments, trials, and care through survivorship. We all have a role to play, and as we organize the administration's response to this mission from here, we will need your ideas, your action, and your change. Stay tuned for easy ways to do that coming very soon. One area with some urgency is in cancer screening and early detection. We know the losses in screening and early detection that we've seen because of the pandemic. We also know that we have a lot to do to get to equitable access to early detection, even under normal circumstances. So we are looking for your best ideas, your best efforts to really make a difference there. And you'll be hearing more about that from OSTP soon. President Biden has a bold vision for how to make progress against this disease, progress that can continue to bring hope to every family facing a cancer diagnosis. We will drive new understanding that can lead to new ways to prevent, detect, and treat cancer. Together, we must deliver more equitable access to quality care. We must bring more personalized and less harmful effective treatments. We must take on cancers today for which we don't have an answer, and we must learn from the perspectives and experiences of patients and caregivers, looking to them as the experts as they are. We will take on each one of the ways in which we know cancer today and make concerted progress toward ending cancer as we know it, together with all of you. So thank you so much for the time to give you a little bit of a glimpse of how we're thinking about organizing around this priority for this president and the administration, and look forward to working with all of you as we do that.
Thank you so much, Danielle. We look forward to working with you as well. I know you have to hop, but we really appreciate your time and spending it with us today. Thank you again.
Thanks, Felicia.
So with that, we've had an amazing first half, and I don't want you all to go too far. We're going to take a much needed break, so please enjoy the music. And we'll be back in 20 minutes for the second half of today's summit. So stay tuned. You'll be glad that you did.
Oh, what fun it is to save up to 70% at Nordstrom Rack. Find great gifts under $25 for every.
Well, welcome back to the Cancer Support Community's Forum on Utilization Management Summit on Health Equity. I'm now excited to introduce Eukarya Borden, CSC's Senior Director of Health Equity, who will moderate our expert of healthcare panelists. Eukarya joined CSC in February of 2020. In her role as Senior Director, Health Equity and Clinical Services, she is responsible for ensuring that CSC headquarters research, program, policy, and operations integrate relevant components of health equity, inclusion, and social determinants of health across all activities. She also works with the leadership of the Institute for Excellence in Psychosocial Care to inform the CSC's affiliate network, including healthcare partners, on best practices in health equity. In addition to a focus on health equity, she is responsible for establishing new headquarters programming, as well as ensuring the highest standard of care for people impacted by a cancer diagnosis. Prior to joining CSC, Eukarya worked for nearly 20 years in direct practice with adults living with chronic illness. 12 of those years included patients in acute, inpatient, and outpatient hospital oncology settings. She is a past president of the Association of Oncology Social Work and is recognized as an AOSW fellow. Eukarya, I'll now hand it over to you for this afternoon's panel.
Thank you, Felicia. It is my absolute pleasure to be moderating this afternoon's panel. Let's start with some introductions. Krista Nelson is trained as an oncology social worker and works in clinical and research roles within the Providence Cancer Institute, and she's a program manager in the Department of Compassion. This blend has allowed her to bring her clinical expertise to work with those impacted by cancer and to creating supportive infusions of compassion to caregivers within Providence Health and Services. Krista is now president of the Association of Community Cancer Centers. Dr. Gary Puckrein is the founding president and chief executive officer of the National Minority Quality Forum, a nonprofit healthcare research, education, and advocacy organization headquartered in Washington, D.C. The mission of Nmqf is to reduce patient risk by assuring optimal care for all. Nmqf conducts evidence-based, data-driven initiatives to eliminate premature death and preventable illness. Nmqf's vision is an American health services research, delivery, and financing system whose operating principle is to reduce patient risk for amenable morbidity and mortality while improving quality of life. Dr. Puckrein received his doctorate from Brown University. Dr. Adrienne Simmons is a pharmacist and advocate from rural Southwestern Virginia. Following the completion of her Doctor of Pharmacy at VCU School of Pharmacy, she completed 2 years of residency training at UNC Medical Center, where she gained clinical and administrative experience in hepatology, HIV, medication access, and 340B. She has experience in federal and state legislative advocacy and has served on national policy committees for the American Pharmacists Association and the American Society of Health System Pharmacists. Adrienne is passionate about amplifying the voices of marginalized communities and improving the lives of those impacted by viral hepatitis. Dr. Surya Singh is the president and owner of Singh Healthcare Advisors, LLC. As senior advisor to nonprofits, private corporations, and publicly traded companies, Dr. Singh provides expertise on healthcare issues with broad impact, including the adoption of novel therapies, value-based reimbursement, predictive analytics, artificial intelligence, and clinical application of genomic sequencing. Previously, Dr. Singh was Corporate Vice President and Chief Medical Officer at CVS Health Specialty. Dr. Singh is licensed and board certified in internal medicine. He formerly practiced as a hospitalist physician at the Brigham and Women's Hospital and was adjunct instructor of medicine at Harvard Medical School, where he continues to periodically teach. I'd like to thank all of our panelists for being here with us today. Each panelist will give a brief presentation, and then we'll all come together for a larger panel discussion. With that, I'd like to invite Krista to kick us off and start her presentation.
All right. I'm hopeful that you guys can see me.
We can.
Oh, good. Okay. Well, thank you so much to CSC for organizing this. And especially I wanted to thank Dr. Winkfield and Dr. Woods, who shared a little bit of their own personal story and how some of the impacts of has impacted them personally. I also want to thank just everyone for the opportunity to be here among these esteemed speakers. I'm excited to hear what you have to say as well. I thought I would start by sharing a little bit about ACCC and what we're trying to do in the space of health equity. One thing that we did start out this year by doing is creating a statement on equity, diversity, and inclusion in cancer care delivery. And I wanted to read it. It says, ACCC stands with its members and the entire oncology community in prioritizing equity, diversity, and inclusion in quality cancer care delivery and within the oncology workforce, regardless of education, opinions, culture, ethnicity, race, sex, gender identity and expression, nation of origin, age, languages spoken, veteran status, color, religion, disability, sexual orientation, and beliefs. We've really made a commitment as an organization to inform all our programming and advocacy efforts through this health equity lens, and really hope to advocate for equitable access to cancer clinical trials and ensure that our leadership, our volunteers, everyone that we work with also represent a variety of backgrounds and perspectives. So I think as we heard from Dr. Winkfield, I felt like it was a kindred spirit there when she was sharing a little bit about how patient access to care can be complicated by some practices. And when we think about the entire concept of as Dr. Winkfield already shared, it's a technique used by insurers to limit costs, and it's not about the providers. The hard part is patients don't understand the difference. And these techniques going to save insurers costs really cost the healthcare system our time and energy. I think cancer programs across the country, we have really expanded our financial advocacy efforts to include pharmacy and other supportive care staff to really help with this critical patient service of pre-auths and support around their costs of care. I wanted to share that literally every day I get a call from a patient, maybe who's not even within my care anymore, saying that some bill was automatically denied and looking for help. And these people, at least I'm grateful that they already have someone that they see as an advocate to help support them. So one thing we're doing, ACCC is doing it as an organization, is really trying to closely align our patient assistance and reimbursement guide with our financial advocacy network alongside the Oncology Pharmacy Education Network. So this guide will be available and is really, really going to help everyone. So I wanted to take a little bit of time talking about the social determinants of health. And I know we have spent some time talking about them and you guys know, but we know that by not paying attention to the social determinants of health and letting there be these barriers, and when you compound that with the financial toxicity of a cancer diagnosis and treatment, that it significantly drives cancer disparity and health inequities. So things like access to food, access to a phone, support systems, transportations are all issues that, thanks to the National Academies of Science, Engineering, and Medicine report, they're formerly the IOM, they had a report come out in September 2019 that's called Integrating Social Care into the Delivery of Healthcare. And really that report insists that healthcare outcomes will improve if you integrate social care. So I want you to hear me say this. Social care must be integrated into medical care. And as a clinical social worker, I wanted to speak. I've heard some talk about navigators and advocates out in the community, but this is what social workers do. And this is what we have been doing. Other social care providers and social workers, we promote better healthcare for all, and we should be central and part of all the healthcare teams. And I think this is the moment where I knew Dr. Winkfield and I resonated, is that I often say social workers can provide precision social care. And it really is getting to know the individual specific person and how to support them, and recognizing whether you use a tool like distress screening, where we're using a patient reported outcome and saying, are you having needs that we're not addressing, but paying attention. I think an example might be if a surgeon comes to me for head and neck cancer and says, I don't have a ride to my surgery. Now the physician, is coming saying this patient needs a ride. I'm stepping back and thinking, okay, this person is literally getting their jaw taken out, and there is not one person that this person feels like they can call for a ride. The issue is much bigger than transportation. It's like, what in the social context will help this person succeed after a big surgery? So, ACCC, under my leadership and before, we have a strong financial advocacy network, and we have this interactive advocacy playbook coming out that will really help, I think, everyone in the healthcare team look at these different options. I wanted to speak to kind of two, I'm sure my colleagues on this panel will also speak to this, but two kind of big policy parts of that really impact patient care. And one is the fail first requirements, and just acknowledging that it's problematic and misaligned with the evolution of how cancer care happens now, how rapidly it is. And I think finding the balance in step therapy, but also having clear, easy to access, timely and transparent opportunities for patients to know that they can appeal that, or there could be exceptions, is so important. And I think we, meaning the collective we of ACCC and people who are providing cancer care across the country, are really having a lot of struggles with these sort of issues and have multiple staff assigned now. And the costs of that, I think, as Dr. Winkfield spoke to earlier, are just unbelievable. I think when I think about the step therapy, I'm reminded of one of my best friends. She died of ovarian cancer about 2 years ago, but her husband is a radiation oncologist, and she was waiting on an insurance approval of a special drug to help support. It took 3 months for her to get that. She was a psychologist. Her husband was an oncologist or radiation oncologist, but she didn't want to bother the clinic. She didn't want to be a pain and ask them. And I think the clinic she was at was understaffed. And we know sometimes the squeaky wheel gets the attention. And she, unfortunately, her cancer progressed to the point where she couldn't tolerate that treatment in that 3-month time period. The other piece I want to speak to, which I'm sure my team here will also speak to, is the issues of white bagging and brown bagging. And just, I'm certain you guys know, but maybe I'll do just a brief definition. So white bagging is an arrangement between the payers and pharmacies, selected pharmacies, to ship a patient's medications directly to the site of care. And then kind of the burden is on the staff of the infusion center. Some concerns come up with that is sort of, are we safely handling the drug, the supply chain integrity, things like that. The other option, the other kind of way that is out there is brown bagging, where actually the drugs are going to the patient. And we did at AAHIVP a study kind of asking the members about their experiences with these two practices. And more than 90 people responded to the survey. 47% said they had seen drug waste occur to those changes. 59% of respondents said their cancer program or practice doesn't allow it, white bagging, and 78% their program doesn't allow brown bagging. So I think when we think about the systemic challenges and the way that policies happen, you can't think about those without thinking about the impact of the patient. And it feels really far from patient-centered care. I wanted to speak just to an experience that I had last night. I volunteer with an organization called Portland Street Medicine, and we go out and serve the houseless with a medical team. And last night I was with a physician, a nurse, myself, a social worker, and a scribe. And we knocked on the tent, i.e. just said, knock, knock, Portland Street Medicine, we're here checking on people. And a guy came out, and you could see a large mass on the side of his face. And I said, hey, I'm just curious. My name's Krista. I wanted to check in. Is there anything you want to talk to a doctor about? And he said, well, I got this cancer here. 2 years ago, I went to the doctor, but they told me I'd have to lose my teeth, and that they said maybe they could get me teeth, but I figured it was more important. And I'm going to wait until I get Medicare, which is in December, to go to the doctor. And I did, we're really patient-centered, not trying to push, but what's going to need to happen there and what will happen is just the continuation of the trust. When I asked him if he'd been in healthcare before, he shared a story. He has very bad diabetes and had gone to the ER. He'd gone to an urgent care. They'd sent him directly to an ER, and that the pharmacy wouldn't allow him to get the insulin that he needed because it was too expensive. And he isn't interested in a healthcare system where the pharmacy dictates the care that his doctor prescribed. Now, knowing in my head, I'm sure the physician tried to order the type of insulin that needs a pre-auth because it doesn't need to be refrigerated because he's houseless. But, in his experience of that, I think I was just thinking today about him. And just wanted to share a little bit about kind of meeting people where they're at. And I think the answer to that is building a relationship. We're going out and meeting him where he's at, and hopefully he'll build some trust and be able to seek treatment. So I'll stop there. Thank you.
Thank you so much, Krista. Definitely some things that you've mentioned that I want to return to when we have our larger discussion. We appreciate your remarks. Next, we're going to move on to you, Dr. Puckrein.
Thank you so much. And I want to thank the cancer support community for allowing me to speak, and you, Karen, thank you as well. So a little bit about the National Minority Quality Forum. We are a research and education organization based here in Washington, D.C. Most of our work has really centered around collecting health data. We've been collecting health data now for about 20 years. We have a database of over 5 billion patient records. We collect data on about 160 million lives a year. And living in the data, we got started because we were really interested in health disparities and trying to understand why in the minority population we were having these poor health outcomes. And as we began to drive deeper into the data, the first thing we came to realize is that these are not random events. These are really structured events that produce the same results year after year after year. And it calls us to look back at what we now call the legacy healthcare system. Legacy healthcare system actually started when inequalities and segregation were by practice and law occurring in the United States. Some of those, the outward facade of that system came down in the 1990s as government came into Medicare and Medicaid to put pressure on hospitals and medical societies to desegregate. But a lot of the infrastructure is still there, the internal infrastructure. And today it gets manifested by what I would call financial risk. Our healthcare system is really built around managing financial risk and not patient risk. So UM is just one of many parts of the system in which the system is, for really the worst reasons, managing financial risk and putting patients at risk. And so as we look at it, you cannot get rid of health disparities in a system like that, because it is actually structured to do exactly what it's doing, which is to pick winners and losers. So that's why when you hear the National Minority Quality Forum talk about managing patient risk, it sounds like a very easy phrase to say. It sounds like that doesn't have very big implications, but it actually does. Because every patient who comes into the healthcare system expects the healthcare system to manage their risk. Their risk for hospitalizations, their risk for emergency room visits, their risk for disability, their risk for dying. I don't know one patient who comes into the healthcare system with the expectation that the system is going to elevate their risk. There's no patient who's coming into a hospital with that expectation. The thing that's happening with the financial risk management of this legacy healthcare system is that it really doesn't talk about the results to patients. So when you think about for example, payers using to manage financial risk, they don't come back and say X number of patients didn't have access to therapy, their disease progressed, they ended up in the hospital, they died, all of those consequences of managing financial risk. What we're now seeing, particularly in cancer, I think cancer is really at the cutting edge of the future of where healthcare is going in this country. And by that, I mean, we are soon going to be able to, in cancer, diagnose patients before they're symptomatic, before the outward manifestation of the disease has occurred. The legacy system, we call that preventative service, right? Because it's built around waiting till the patient shows outward signs. The challenge is, as we move into that new world with the technology and the capabilities that we have, the legacy system is not going to be able to keep up. It's going to try to force us back into the 20th century as opposed to helping us move forward in the 21st century. And so the reason why I talk about legacy system, because we need to give ourselves permission now to reimagine a new healthcare system. It is not just we shouldn't think of in isolation. It's part of a larger problem, a larger system that has historically picked winners and losers. And really, at the end of the day, what we want our healthcare system to do, its only purpose, is to make sure that every person who comes into the healthcare system gets optimal care, that we're all working collectively to manage their risk. And I just think that the legacy system is incapable of doing that. And I think the pressure is going to come, particularly as new technologies come on stream, biometrics, telehealth, all of those things are going to put such pressure on the legacy system that we are absolutely going to have to reimagine it. And so the National Minority Quality Forum, that's where we're committed to. We're committed to reimagining a new healthcare system and talking about how those pieces come together to make sure on one side, we're managing patient risk, on the other side, we're spending our Medicare dollars wisely. Thank you.
Thank you so much, Dr. Puckrein. Dr. Simmons, coming to you next.
Awesome. Thank you so much for the opportunity to be a part of this discussion today. My name is Adrienne Simmons, and I'm the Director of Programs at the National Viral Hepatitis Roundtable, also known as NVHR. NVHR is a national coalition of patients, providers, community-based organizations, and public health partners fighting for an equitable world free of viral hepatitis. I'm thrilled to be discussing the ways in which utilization management strategies increase health disparities and viral hepatitis care. I'll start by providing a bit of background before discussing UM strategies. Viral hepatitis is an inflammation of the liver that is primarily caused by an infection with hepatitis B virus or hepatitis C virus. The CDC estimates that in the United States, 850,000 people are living with hepatitis B and 2.4 million people are living with hepatitis C. The most recent data shows that while hepatitis B rates remain steady, hepatitis C rates continue to rise because of the opioid crisis. If left untreated, chronic infections can lead to serious health problems such as cirrhosis, liver cancer, and death. Although hepatocellular carcinoma is not a very common cancer in the United States, it remains a common cancer and cause of cancer death in the world. In 2020, liver cancer was the third leading cause of cancer deaths and the sixth leading cause of cancer incidents. In the United States, there has been an estimated 42,000 new cases and 30,000 deaths from liver and intrahepatic bile duct cancer in 2021 alone. About 65% of hepatocellular carcinoma is associated with hepatitis B or C. We see stark disparities in viral hepatitis and liver cancer. Hepatitis B disproportionately impacts African immigrants, Asian immigrants, Asian Americans, and Pacific Islanders. These communities make up the highest rate of hepatitis B infections, despite making up a lesser percent of the US population. When we look at hepatitis C, we see that Alaska Natives, Native Americans, and Black Americans disproportionately have high infection and mortality rates. In fact, the rates of acute hepatitis C and death are highest among Indigenous communities. Similarly, we see the highest rates of liver cancer among Asian, Black, Indigenous, and Latinx communities. In addition to racial and ethnic disparities, there are disparities among the communities most impacted by the opioid crisis. Specifically, people who use drugs and people experiencing homelessness account for most new hepatitis C cases and a large portion of new hepatitis B cases. We also see stark differences between rural and urban communities, particularly in Appalachia and the southwestern part of the United States. Because of the war on drugs, we see astonishing viral hepatitis infection rates among people who are incarcerated. It's estimated that the prevalence in state prisons is as high as 39%, yet only 3% have access to hepatitis C treatment. We also know that communities of color are incarcerated at a higher rate than the rate of white communities, further highlighting existing inequities in access to healthcare. Despite these disparities, we have a vaccine and treatment for hepatitis B, and we have a cure for hepatitis C. Yes, you heard that right. We have a cure for hepatitis C, a word that we don't often hear in the cancer community. So you might be wondering, in addition to systemic racism, what's contributing to these disparities? Why are people still getting liver cancer? That brings us to the crux of today's discussion, which is utilization management strategies. I'll start with hepatitis C, where we've most acutely felt the impact of these strategies. Prior to 1992, most people infected with hepatitis C were infected through blood transfusions for routine procedures because at the time we weren't screening blood transfusions for infectious diseases. When direct-acting antivirals were approved in 2013 as the first curative therapy for hepatitis C virus, the assumption was that the number of people living with hepatitis C was largely concentrated among people born between the years 1945 and 1965, also known as our baby boomers. However, in recent years, the opioid crisis has fostered a new wave of hepatitis C infections among younger people who inject drugs. Today, we can cure hepatitis C virus by taking a pill a day for as little as 8 weeks. However, the existence of a cure does not always mean that everyone has access to a cure. Since 2013, insurance companies have been using strategies like prior authorizations to determine who is deserving of a cure. My organization works with the Center for Health Law and Policy Innovation at Harvard Law School to track authorization restrictions in Medicaid programs. We track prior authorization requirements for hepatitis C treatment based on 3 criteria: liver damage, sobriety, and prescriber restrictions. Liver disease restrictions require that patients reach a certain level of fibrosis. Sobriety restrictions require a period of abstinence from substances or alcohol. And finally, prescriber restrictions dictate that only certain specialists, such as a hepatologist, may prescribe treatment. Today, sobriety restrictions remain the most pressing and widespread barrier to accessing hepatitis C treatment. While many states have reduced restrictions regarding periods of abstinence, screening and counseling restrictions continue to amplify stigma surrounding alcohol and drug use. The inclusion of questions about substance use and adherence on prior authorization forms creates the opportunity for providers to discriminate against patients based on non-evidence-based assumptions. Thanks to advocacy and litigation, we've made significant progress in increasing access to hepatitis C treatment. Since we began tracking these criteria in 2017, 32 states have either eliminated or reduced their fibrosis restrictions, 21 states have loosened their sobriety restrictions, and 25 states have scaled back their prescriber restrictions. There are also now 8 states that have removed prior authorization for treatment entirely. However, the remnants of nearly a decade of utilization management strategies that sought to control costs undoubtedly contributes to the stark disparities we see in liver cancer and mortality rates in marginalized communities. In addition to hepatitis C, we also see utilization management strategies being used in hepatitis B care. The Hepatitis B Foundation has done a wonderful job documenting the impact of strategies such as prior authorizations, step therapy, and quantity limits. Examples of these strategies include placing generic drugs on high tiers or placing all drugs for hepatitis B on a high tier so that people living with hepatitis B have high out-of-pocket costs for their medication. Most plans do not cover all medications that someone with hepatitis B might take. And in fact, most plans do not cover the newest treatment for hepatitis B, which is one that lacks a generic alternative. Together, these strategies delay and restrict access to care for our most vulnerable communities. They not only allow the health of these individuals to deteriorate, but they also undermine public health efforts to eliminate viral hepatitis by 2030. As health inequities and lack of access to sterile supplies continue to drive rising viral hepatitis infection rates, we must continue to hold policymakers and insurance companies accountable for ensuring that all people living with viral hepatitis have access to treatment that's consistent with guidelines and federal and state laws. We have the tools to eliminate hepatitis in the United States, but it requires a revision of utilization management strategies, as well as leadership and resources to turn the promise of a cure into a reality for all. Thank you for your time, and I look forward to the discussion.
Thank you so much, Dr. Simmons. Dr. Singh?
Hi, thank you so much for having me to the cancer support community. I think it's been a great discussion so far. It's hard to go last after 3 great short presentations there for the panel. And I actually think, which I'll reference back to, there's more things that I have to say in common with the other panelists. And I have a couple of things in particular Dr. Puckrein brought up that were very similar to points I wanted to make. But just to make sure that I stay on time here and we have time for Q&A, I'm going to dive in and I'll shorten up one of the sections of remarks. I suspect it will come up in the Q&A actually. So the 3 things I really wanted to talk about are the increase in proliferation in precision healthcare, precision oncology, and precision medicine, which I think is underappreciated as a vector, as a movement that will change the face of how, even in its current iteration, is performed. That's, might seem like a micro point, but I have a couple comments about that. The second thing, which was covered very nicely by Dr. Winkfield, which I had planned on talking about, and I'll be a little briefer on, are social determinants of health, and how I think payer organizations and managed care in general can do better and are trying to make improvements on how they use social determinants of health to try to both, and again, I know the topic for today is specific, but and this is something that Dr. Puckrein said that I think resonates strongly with me. That's one part of a much broader context of how patients are, and how care is managed by managed care organizations. And we've done, I think, not a great job in managed care and lagged in being able to use the richness of the analytics and data that's available to try to help people from a social determinants of health standpoint. That information is available and could be used more broadly. The third thing is, bigger picture, that as we try to move, and I often talk about it, instead of a legacy system to a new or progressive system, just from sick care to well care. And as the system tries to make that move, there are a lot of things that stand in the way. And we're focusing today, again, because of the topic, on practices, but I think there's a lot of elements of the fee-for-service system that we have and the behaviors that it incents both from the provider community, that we have to make sure that we have good policies to try to control or stamp out and at least cap, because it leads to a lot of behaviors that none of us want. None of us want more services and more stuff to be done that's not increasing, improving patients' outcome and increasing the quality of care. So just to start with the first one in precision health, I think oncology, has had this great proliferation of availability of specific genetic tests. And we talked about BRCA. A couple people mentioned the BRCA gene in breast cancer, also used in ovarian cancer. And then we have, a couple people also talked about genomic sequencing. And just for people who are less familiar with it, instead of point genetic solutions, sequencing whole parts, looking at multi-gene panels, and even sequencing the entire tumor, getting some tumor cells and sequencing the whole thing, that is the future. And the more that we can adopt those techniques to be able to guide care, so that insurance companies, as well as anybody who's overseeing large provider organizations, are sure that patients are getting the most targeted, most precise treatment possible for their cancer at the time that's initiated, that's what we want to do. But I'll just give you the stat that I found, the most recent paper published on this in 2019. Okay, and this is in ovarian cancer, specifically for BRCA, which is widely standardized and available. Everybody should be getting this, okay? I looked at it specifically from a health equity standpoint and disparity standpoint, given the topic of the day. In breast cancer, I won't go into the rates because there was not a statistically significant difference between the rate of BRCA testing in the breast cancer patients in this big analysis of the SEER registry. For those of people, I could explain that, I won't take the time, the big surveillance registry that we have in the country. But for ovarian cancer, it was quite different. So Black patients got BRCA testing when they were diagnosed with ovarian cancer at a rate of 21.6% versus white patients 33.6%. So pretty big difference. And then the other categorization they looked at was uninsured versus insured, 20.8% versus 35.3%. So pretty big difference. But let's not focus on the difference for a second. Let's focus on the absolute values. Why are even at the max rates about a third of patients getting BRCA tested? We as a system are doing a horrible job of using the technologies that are available. So one thing I want to push back on is the notion that is only to control costs. No, I've sat in a major payer organization, as you heard in my overview, and a lot of the times the discussion is around both costs, but also things like this. Why are we not getting this testing done? That's a very good example of why we would put that into the program somewhere to say, this testing has to be done. You have to show me the lab result. Physician, before you need to submit to me at the time the patient is diagnosed this lab result. Why do we do that? Because the testing is not being done. So show me an objective analysis that gives us even over 50%. There's nothing out there because it's not being done. Same thing for Oncotype DX, which Dr. Winkfield mentioned. So if I zoom out and take a broad lens on the healthcare system, we have got to do better at driving adoption of technologies we know are going to help patient outcomes. And we should all be united in that. We end up, because we end within managed care, having this teachable moment, this point in time when you can offer a check, that you try to get those things done. And I could cite examples of how much we were able to increase EGFR receptor testing and lung cancer and other things like that, right? We put specific pieces in place. But I just make one other point on the precision side before going back to the value-based reimbursement side and fee-for-service system. Payer organizations, I think, are getting better at being able to use the data as it comes in to modify their, specifically prior authorization, but their practices in general. And I'll give you one example. So while I was CMO of specialty at CVS, I would have these reports coming to me on how many times denials that we had issued were appealed and then overturned. And I kept on seeing, month by month, that pediatric oncology drugs, almost all of, will give you specific numbers, I don't have them in front of me, but it was extraordinarily high, the number of the denials that were appealed and overturned for 14 different drugs. I just went back and looked at the number before we got on the call. It took me a long time, and I won't go into the mechanistic details within the organization how to get this done. We ended up removing the PA requirements in those 14 drugs for kids. Why do we remove that requirement? The reason we removed the requirement is because what's the point in doing it? All we were doing was delaying care for children and their families. So it's a relatively small example. It was, in our world, pretty big, but I think the industry is coming around to the fact that if it's not doing any good, we should remove the requirement, especially if it's ending up just delaying care. So I don't want it to seem like it's not a dynamic world. Obviously, we could all look at our own organizations in different ways, especially on the provider side, and say they move too slow. Payer organizations move too slow for me too. But I think there is, sort of a willingness to look at how we can use the breadth of data that we have coming in and newer technologies. The other, quick thing I'll give you before I have a couple comments about the fee-for-service to value-based payment transition is that prior authorization, again, just specifically talking about that part of which is more common in cancer care, as you guys know, than step therapy. Prior authorization is becoming more and more, it's not fully automated, but a process where the forms are 80 to 90% filled out before they get sent to the provider to fill in the last pieces. So there are, for whatever it's worth, of the oral oncology drugs, about 80% of them now, the form can be completely filled out, and all the provider has to do is look over the information and submit it. So that this whole part about the administration costing so much, and we talked about the $40 million per year for radiation oncology. I'm glad Dr. Winkfield clarified that, because my figure is it's over $500 million in administrative costs, which was the last paper that I saw in JAMA on this earlier in the year. I think that was like 2019 data. But so it's an extraordinarily expensive practice, but the cost as the technology is rolled out to more and more combinations of large provider organizations that own their oncology practices and payers for the cancer ecosystem should continue to come down. And cancer is a big chunk. I don't know the chunk specifically of those costs, but cancer is a big part of it. Okay, last thing I'll say, and then I'll stop, is in the fee-for-service system, sort of transitioning to value-based payment, I would just, make a couple of observations. One is that I totally agree, and I'll use Dr. Puckrein's language since you've heard it already. The system is set up to manage financial risk, and I don't usually call it patient risk, I call it clinical risk. But that is to me, that is absolutely true, and it's something that we have got to change. It cannot be run by just what is the actuarial risk. That's not what we think about when we're as doctors, and I've taken care of patients, thousands of patients, not what I think about when I'm with the patient, right? But however, the economics of the system, and we all know, and we're at a cancer conference, so I'm going to say it anyway, even though it's not a popular thing. Unfortunately, buy and bill in oncology led to a lot of decisions that I'm not comfortable with in terms of what treatments were prescribed for patients for a number of years in outpatient infusion centers. That is a very unfortunate part of now what I think is our past. I think we're moving away from it. I don't think it's a current problem, it's a past problem, but I think it's a harbinger. It's an example of what we need to make sure we prevent again, which is a good policy, because you don't want to put financial and economic incentives in place for physicians or anybody else to make decisions that benefit them economically. That's a dangerous place for all of us to be. And everybody points to payers, and rightfully so in many instances, but I would say we should shine a light on all parts of the industry and make sure that we're fair about who's being economically incented where, because what we should really be about is what's going to drive patient outcomes, what's going to drive the best outcome for the patient.
Thank you so much, Dr. Singh, and thank you to all of our panelists today. I've been keeping some notes as you're talking, and I have several. I want to highlight a few things, and then there's some questions that I want to get to. As I've been listening to all of you, including Dr. Winkfield, there are some absolute themes that you've all touched on. We're talking about the system quite a bit, called by different things. We're talking about a legacy system that has us stuck in sick care and not well care, the system that's not progressive. And Dr. Singh, you gave us an example of a change that you and colleagues were able to make in that system, as you talked about the delays that occurred for the 14 drugs. And as we're thinking about these problems that can feel so overwhelming, can you walk us through what it was like to make such a monumental change that was leading to those delays in care?
Yeah, I think for me, it starts with trying to have a group of people who are willing to look at data instead of make assumptions. And so it really has to start with, having, I guess, basically both a group of people and a set of analyses, because so many of these organizations now in the current world are driven by looking at data. To say you can't continue to operate off anecdotes and assumption. We have data to show us that we're ending up, if you want to, make it about cost, or you want to make it about quality on both axes, appropriateness of care is what I mean by quality in this instance. We are not reducing costs, and we're not increasing the appropriateness of care with these PAs in place. And we have data to demonstrate that. We're paying for them anyway, and it turns out they were appropriate, because those that get punted out for peer-to-peer review, for an oncologist review, are getting approved almost 100%. So what's the point? Why are we doing this? But that being able to ask that question, starts kind of step one is getting the data together. Step two is having someone who is able to champion it within the organization and continue to beat the drum that it doesn't, let's not let inertia rule what we do. Because we all in our professional and personal lives to some extent are ruled by inertia, and we end up just getting into the habit of doing things that are not particularly constructive. And I think in this instance, it's the same thing. So it takes, rather than just hearing somebody like me saying it, it would have never happened if I didn't have excellent data from very good analysts that everyone trusted, and that the data that people trusted to be able to present. Then you have to have an organization that's willing to receive that and say, yes, we can rally around making some change. So it takes a couple of steps. I will say, from the standpoint of sort of cancer advocacy organizations, there were a couple of organizations that were important for me to hear. I mean, we've heard it said a lot, like ask the patient. To me, I always say, when I'm asked about this, no, patients, like any other group, are not a monolith, and neither are the organizations. So we tried to get different organizations that represented pediatric cancer patients in this instance that we were talking to about whether or not they had seen across other organizations prior authorization in place for these 14 drugs. So we actually reached out to them and said, to your knowledge, are there prior authorizations in place for these 14 drugs? Trying to figure out, are we out of the norm and having all of these, having as part of our medical policy, having PA in place? And it turned out we weren't, but we took them out anyway. So, but again, that was a countervailing force to removing the PA requirement. But it all came back to having the information, the data to be able to say, we're ending up approving these anyway. It's just taking time, 2 to 4 weeks on average.
Thank you so much. And, as we're thinking about, these systems and the changes that are required, we do have a question that's come in that's specifically aimed at what patient advocacy organizations can do in this space. And the question is, step therapy and prior authorization are thought of most as utilization management techniques. But formulary design and tiers and high deductible health plans impose great barriers to access, mostly to low and middle income patients, which you've all certainly touched on today. What can patient advocacy organizations do to expand the discussion so that these policies are not just accepted as the way things are done? Dr. Puckrein, would you like to start us off with a response?
I think patient advocates are the catalysts in the system. The system is stuck. I was listening very carefully to Andrea's comments, and we could replicate those comments across disease states, right? Because the whole healthcare system itself is so committed around financial risk that it's lost sight of the patient. I see the conversations going on between doctors and hospitals and pharmaceutical companies, and they're all talking back and forth, and they've all lost sight of the patient. And the only one that can get everyone back to center here, and center is the patient, or patient advocacy groups. But the challenge for patient advocacy groups is that they have to have a common language. You can't do it as one-off therapeutic areas. You have to come together and share a common language and message, because you're actually saying the same thing. What we want is to get the system to manage patient risk. And as we do that, it'll transform from a sick care system to a well care system. And I think in the long term, cost will come down because we're in the business of curing diseases, right? At the end of the day, we don't want to get to 2050 and we're still wrestling around with a bunch of these diseases. I mean, we failed if that's the purpose, to hang around here with these diseases. Then I think we've lost sight of what we're supposed to be about. And the point is, different from the 20th century, we have the science and technology to change. It's not that we can't do this, we can do this, but we're not organized to do it. It's because the legacy system operated at a period when, the technology was, at best, maybe could give you a little palliative care, slow you down a little bit, but it wasn't curing hepatitis C, right? It wasn't doing that. But now we can. But you look at hepatitis C and we say, oh, that costs too much to cure people. I mean, that's like an insane comment. It's too much money to save lives. And so I think the group in the healthcare system are the patient advocates. They're the catalytic agents for change. And it is their voices and their advocacy that I think will put the pressure on the legacy system, because it's not going to do it on its own.
Thank you. And that relates back to something you said, Dr. Simmons, and it really just struck a chord in me because it's something that we know, but to hear it in these words, you said, the health of individuals is allowed to deteriorate. That's heavy. That's really heavy, especially when you follow it with something that Dr. Puckrein said as he referred to what you said, which is that we do have the tools to eliminate. And we can leave that as a blank because there are so many tools to eliminate so many things, yet the health of individuals is allowed to deteriorate. That's maddening. Would you like to expand more on that?
Yeah, I appreciate all of the comments that have been made thus far, and maybe I'll first just respond to, as someone that works for a patient advocacy organization, how we are engaging patients and really empowering them to lead these discussions around prior authorization, step therapy, formulary design, and so on and so forth. And, it's easy. I agree with everything that's been said, is that, the patient is really our most underutilized resource at this point. But what I think people fail to realize is that, the group that's serving on this panel, we sit and have these discussions all day, every day. But when we think about including the people that are most impacted and really having them lead the discussions, a lot of times that means that they need training to be able to tell their story. And so to Dr. Puckrein's comment around, speaking a common language, well, it's our responsibility to help train up those patients to be able to tell their story most effectively. And so I think that that's something that every patient advocacy organization has to keep front of mind. We're always helping advocates on the ground, whether it's a patient or a provider, arming them with the resources and the language that they need to talk to policymakers, whether on the state level or the federal level, about what changes need to be made. But you have to do the legwork. You have to help prepare them. You can't just assume that they will know what the right words are to say to resonate with people like us. in terms of your question around allowing health to deteriorate, hepatitis C is a really unique example in the sense that, particularly in the context of cancer care, here we're using prior authorizations historically. When this curative therapy market, we put rules in place that said, we will not cure your hepatitis C until you nearly have cirrhosis. That was the requirement. That is what the prior authorization criteria was, is that you have to have severe liver damage in order for us to treat you. And so when you think about a baby boomer living with hepatitis C, perhaps for 30 years, they're already, approaching liver cancer at that point, right? And so here, when we finally get access to a cure, we still put those barriers in place to say, well, if you're not quite there yet, you're not quite sick enough. And so we need you to wait. We need you to be a little sicker before we'll treat you. And that is just, incredibly disheartening, obviously, for a patient, but also embarrassing as a healthcare system. We should be embarrassed that that was our policy. And in some states, it continues to be the policy. So I think to the earlier points that have been made around our system needing an overhaul, I think we can all agree about that. But in particular, hepatitis C is unique in that we have these very inhumane requirements around who deserves healthcare.
Thank you, Dr. Simmons. And Krista, you gave us some very specific examples of, just how utilization management plays out in someone's everyday life. And I'm wondering if you can help us to understand what are some of those strategies that Dr. Simmons is referencing as we think about, including those patients and survivors and caregivers like in this discussion. What are some of the strategies to empower them? Certainly, Dr. Winkfield gave us one example, helping them to understand that a call from you is something that you can do, something that could make a difference. But how are you and your colleagues making a difference in patients' lives?
Well, thank you so much. And I appreciate, Dr. Simmons, your comments. I think one thing I've begun to learn, and I think that people on this call are aware of, is that we are in positions of power and privilege right now. We're presidents, we're whatever, there's a lot of powerful people on this call. I think we all need help in supporting each other, and our patients need advocates. And so as much as we do, I think Dr. Simmons talked about educating our patients, we also need to step alongside and support people along the way. I think some of the advocacy that could be done, sorry, Carrie, to shift a little bit,
That's quite all right.
is around thinking about payment models. When we think about how value-based care is coming, and we're moving away from fee-for-service, that value-based care needs to include in it provisions for addressing social determinants of health, whether that's new technology that does that, it's people that do that. And somehow it's almost like, I wish there was a prior auth, like, did this patient meet with a social worker before you're going to give them their house list and they're going to get a medication that's going to give them diarrhea? It's like, we need to make sure that we are addressing these social determinants of health. And I think addressing how it's paid for. We can't just continue to put strain on healthcare systems. I mean, as we all know, everyone is extremely burned out and stressed out. So to add one more thing, just even if it's just signing a form, when you were talking about that, Dr. Singh, I was thinking about the piles of forms that I see when I go around from doctor to doctor, and recognizing that those are patients' lives that are very anxious and waiting for those. And when a patient reaches out to me, I can pull their piece of paper forward. But I think the truth is our system does need some change. I think as far as empowering patients, I think a very easy strategy is anyone in healthcare should absolutely have a patient advisory board, and even advocacy groups. I know they're just experts at this, and we're continuing to learn from them. But making sure that these advisory groups include people who can't get there easily. So for ours, we made it that we had gas cards available, and that we weren't meeting in the middle of the day where people are maybe working, and had varieties of time. So making sure that the people that we're concerned about actually do have a voice. And maybe it's us as leaders that help extend their voice and tell their stories.
Thank you so much. And that pivot to advocacy is completely appropriate because that is what it's about, especially helping our patients to understand that they too can be advocates, which is something that we've already heard many things about today as well. Dr. Singh, there's a question that's come in for you. The question is, but don't payers have restrictions around genomic testing too? Lots of payers won't pay for BRCA testing except for certain people.
Yeah, no, I think that's a very good question. Whoever wrote that, it's a moving target. So a lot of the, and I'll just broaden it from BRCA testing to genetic testing and cancer in general. It's diagnosis based now for a lot of payers. So if you have even one claim for non-small cell lung cancer, breast cancer, whatever it is, then all of the diagnostic tests for that cancer type, if you've been diagnosed and you've seen an oncologist, are unlocked, so to speak. So there's not a requirement for, or not, sort of restrictions or prior authorization for that for BRCA testing anymore. I would say, just for me personally, I advocate that I don't think that the diagnostic tests should be subjected to the same, PA in particular, but utilization management techniques, but not all payers feel that way. So there still are some payer organizations that put restrictions on diagnostics, which in a different way, instead of the delay being on therapeutics, delay the process as well. And I think that's to the person who wrote that, I think it's a huge problem for the regional payers still doing that. The national payers largely have stopped that. But.
Thank you. We have a few moments left, and I want to return to something that you've all touched on in a way, and it's really the larger implications in the life of a patient who's had to fail first or who's had a delay. And it's something that Dr. Winkfield mentioned earlier, which is about how utilization management fuels some of that mistrust and distrust in the healthcare system, in the provider, in the systems that are in place all around them to supposedly give them the care that they really need. And I just wanted to open that up for discussion. If there's anyone who wanted to make comment on that, because that is, it's major. It's something that, if you can't trust the system that's supposed to give you care. Dr. Puckrein, you've talked about the system that's not even set up to do the thing that patients think it's there to do. So this idea of mistrust in the health system is really foundational, even though the system may not be focused on that. So Dr. Puckrein and then Krista, please.
First of all, I would say patients are absolutely correct to distrust the system, right? Because it's not set up to manage patient risk. And I don't want to point to payers to suggest that somehow they're the ones who are doing this. No, we've collectively done this. We've collectively put together a system that manages financial risk. I've sat in meetings with patient organizations where they start to prioritize the finance. Well, we can't help everyone. And so we have painted ourselves into that box where we can't even imagine the future. We can't even take this wonderful technology that we're learning and save lives. We question ourselves when we do it. And so, quite frankly, I think every patient who comes into the healthcare system ought to know that care is being restrained because of the way we're managing care. And it has no color to it. I mean, I'm focused on disparities, but it's impacting everyone in the system, except those who are very, very wealthy and can go buy what they want. But for the rest of us, the system is worthy of a little bit of distrust.
Maybe to just jump in that, I think I have an example of something that happened yesterday. So I work in stem cell transplant. I had a patient who's about 3 months out, and she's looking to get her COVID vaccines again because she's got a new immune system. And she came across no pharmacy being willing to give her a vaccine because I live in Oregon. So the Oregon Health Authority already had her as having 3 vaccines. And just the frustration and the panic and the hours that she spent trying to negotiate that. But on a happier note, it took her reaching out to someone in a position of power. She reached out to me. I Googled Oregon Health Authority Advisory Committee found some poor person doctor that I don't know's name, emailed him, and literally this morning, the CDC changed the recommendations on the website. Like that has never happened that fast in my entire career. But I think it just speaks to her, you know, she's been through transplant and felt like we weren't there to help her, even though she's been kind of held in this treatment. So I think it is around connecting patients with people who have a louder voice and can amplify their voice as well.
Absolutely. Thank you so much. And you know what? I want to continue this discussion, Felicia. I completely understand what you mean, because I think there's so much more that we could continue to talk about. However, we are at time for our panel and discussion. I really just want to thank all of you so much for sharing your insights with us. And with that, Felicia, I will turn it back over to you.
Thank you, Eukarya, and thank you to all the panelists. I agree with you, Carrie. I think we could have continued this for a little while longer, but I'm just grateful for everybody participating today and sharing your expertise with us. We're so grateful for you taking the time to discuss this important topic. And just a few nuggets, I really think that and agree with Dr. Puckrein that the challenge for patient advocacy organizations is that we do need to develop that common language. And I hope that as we continue to move forward and focusing on health equity, focusing on inclusion, and also community engagement, that we're looking at ways to craft that language where we can uplift and ensure that patients are more at the center of advocacy, and that they are hearing directly from, and that policymakers are hearing directly from patients about those critical needs that they need when it comes to care, so that we can move from a sick care model to a well care model. And so again, I thank you all for joining us today. Just as a reminder, today's summit was recorded. So if you missed any of today's incredible speakers, no worries, you'll be able to view it afterwards. Again, thank you to our Forum on Utilization Management sponsors. And also I would just like to thank all of our attendees for joining. And please reach out to the Cancer Policy Institute at our email address, action@cancersupportcommunity.org, if you have any questions, or if you would like to join our grassroots network. Thank you again and have a great afternoon.